for the kind introduction. And really, entire country is actually thankful to NABL for the fight against COVID-19 for accreditation. And I really, take an honor to say that I'm also an NABL assessor. So at the outset, I must thank the organizers for organizing this wonderful conference, and also thank the esteemed, respected chairpersons. And good afternoon to the august audience. So we have seen in the last 2 years, so a lot of the stewardship activities, antimicrobial stewardship activities got derailed, severely derailed, I would say, because of this COVID-19. And also, parallelly, good interest and awareness on molecular diagnostics. So this is a situation where perhaps we can marry these two and can extend this heightened awareness of molecular diagnostics to streamline our stewardship practices in a proper quality environment. So my next 15 minutes will talk on these aspects. So I'll begin with the global burden, why you are concerned about this stewardship and why this antimicrobial resistance come into picture. The global burden associated with drug-resistant infections assessed across 88 pathogen drug interactions combinations in 2019 was an estimated 4.95 million deaths, of which 1.27 million deaths were directly attributable to drug resistance. And also this analysis has shown that this AMR, that all age death rates were highest in LMICs, that includes India. So by any metric, bacterial AMR, antimicrobial resistance, is a leading global health issue. So when we speak about this drug resistance index across countries, you see that India is having the highest DRI among all these countries, close to 80. And global deaths attributable to and associated with bacterial antimicrobial resistance by pathogen, we see again E. coli, then surprisingly Staphylococcus aureus, then we have Klebsiella, Acinetobacter and all. So these are the leading killers, and this is a silent pandemic which is going on. So again, coming to Indian data, in a 2020 study, over 17,000 hospitalized COVID-19 patients revealed that a lot of patients actually died of gram-negative infections. So 78% patients acquiring secondary GNB infection and 72.8% Klebsiella pneumoniae, and 2 to 3-fold increased bloodstream infection rates in most hospitals. So I think it actually hit our quality practices, all our stewardship activities badly. So there's an urgent need to reinforce infection control and antibiotic stewardship in every sector. So when we look into this interaction between antimicrobial stewardship, diagnostic stewardship and infection prevention, we understand this is very closely interlinked. So when a patient comes, the diagnostic stewardship begins with the right test, right patient and right time. And when the test is followed, completed with a best quality environment, and then begins the journey of antimicrobial stewardship with the right interpretation and also right antimicrobial again at the right time, so that the patient can be benefited appropriately. So the key questions that rapid molecular diagnostic would address: is the patient infected or colonized? That's a million-dollar question. We see a lot of antibiotics being abused or misused when there is zero sepsis, there is no sepsis at all. Whether the infection is because of bacteria or virus, pathogen diagnosis for clinical syndrome and direct detection of pathogens from blood or positive blood culture, and rapid antibiotic susceptibility testing and rapid detection of resistance mechanisms. So initially, does the patient have infection of sepsis? Yes, we have certain newer options coming up in the name of transcriptomics in risk profiling. So whether the patient is infected or not infected can be detected or determined by bacterial or viral metascore. We have meta-analysis of 31 studies having more than 6,000 patients that the molecular rapid diagnostic test definitely helps in reducing bloodstream infections and improving antimicrobial stewardship programs. And coming to the syndromic approach, yes, I think perhaps this is the way forward. And the syndromic approach represents a new line of diagnosis against infectious diseases by using a single rapid test for the most microorganisms responsible for infectious disease. So now there is no time for trial and error. We need to understand the causative organism as early as possible. What are the present challenges? Now the time is a challenge. The present standard of care, which depends on culture-based initial diagnosis, takes around 40 to 72 hours. Cultures are often negative because many times antibiotics are given before sending cultures, and viruses and parasites are often detected by indirect means, and ineffective antimicrobial therapy increases mortality rate. So there is no doubt with that. And use of unnecessary empiric antimicrobial agents increases the global antimicrobial resistance. So this is where the possible reasons where PCR detects organism but culture cannot, that fastidious organisms. When you start antibiotic in certain situations, you have to start antibiotics because of logistic issues before you actually collect a sample. And variability in normal oral flora definitions and reporting, samples transport, patient immune factors. So a lot of pre-analytical factors here comes in, which actually affects the qualitative report or the quality of the conventional pathway. But here PCR can have a better edge. So the solutions at hand, first of all, this is easy, few minutes hands-on time, fast results available in minutes to an hour. And we have comprehensive panel. So respiratory panel coming from gene expert, coming from BioFar, blood culture panel, gastrointestinal panel. We have meningitis, encephalitis panel, and also sexual health. So these are the cases where we see a lot of misuse or abuse of antibiotics because delay in diagnosis. It offers a contamination-free closed system with small footprint where you need no molecular skills and no sophisticated setup required. Minimal molecular skills, I would say. So can detection of resistance mechanisms assist with antimicrobial stewardship in addition to impacting infection prevention? Yes, so this is a much talked after slide. So we need to know these resistance genes these days. So this is where molecular detection can prove to be helpful over the conventional systems. And these are the different types of carbapenemase genes which are there. In India, we have NDM, but also we have other carbapenemase genes available in our country. So we have again data that how the NDM1, which is a very common carbapenemase gene, which adversely affects patients with high bloodstream infections. Coming to CPE screening, what is CPE? Carbapenemase producing enterobacterials. So where do you need to screen them? Yes, we have a lot of platforms available for screening, but not everything available in India. So here, if we can borrow some slides from WHO, yes, we need to implement a certain strategy to prevent and control the spread of carbapenem-resistant organisms. So there has to be a national initiatives. There are potential barriers and solutions. There are, definitely, and it enhances the usefulness of surveillance and screening. So WHO has very clearly laid out, a criteria for selection of test, which depends upon so many factors, but the local carbapenemase prevalence, turnaround time, ease of use, these are primary. So this is a very interesting slide, why there is a reluctance to use molecular diagnostics tests for carbapenemase producing organisms. So, and trust me, this publication comes from US. There is a sense that differentiation by carbapenemase resistance gene is simply unnecessary. People think that, well, we have automated system, we don't need to go into that genotypic level. Laboratories tend to assume that any gram-negative enterobacteriaceae isolate that tests as resistant to any carbapenem is a carbapenemase producer. So there is a myth. So carbapenem resistance does not mean that patient is having or that bug is harboring carbapenemase gene. So carbapenem resistance can be attributed to by other mechanisms. So there is a need that we need to understand what may be the other additional pathway. So why would we need molecular detection? Because fast availability of results, higher sensitivity and specificity, possibility of detecting enzymes, co-expression by molecular platforms. This co-expression is very useful when you preempt your antimicrobials, and information regarding mechanism of resistance may aid in outbreak management. Finally, local, national, global surveillance of AMR is possible with this data. So again, if I refer to this UCAST, screening of carbapenemase production, this is a phenotypical. So we have data to prove that IMP and OXA48 can be missed by phenotypic method, which can be picked up by genotypic method. So this can actually adversely affect patient's outcome when you select antibiotics accordingly, phenotypically. So culture-based versus molecular detection of CPE, a molecular is sensitive and specific, turnaround time fast, but it requires continual updating. Acquisition cost may be apparently higher, but if you look into the overall cost, this may be quite all right. So this is an Indian publication, so these are the platforms available in our country. You have lot of platforms actually, but again, not many things available in India, but we have expert CARBA-R available. So these are the genes which are detected: KPC, NDM, VIM, OXA40, and IMP. So for screening, you take the help of rectal swab and perirectal swab, and this is how this is collected. And for a high-risk patient, which you can define for your population, maybe immunocompromised patient, maybe transplant patients, so you can screen and you can actually stop the spread of infection to other patients. And also we have data to suggest that if these patients are having heightened chance to develop carbapenemase producing CP infection later on if their immunity is further decreased. So do you have any reference, Indian reference? Yes, we have Indian reference coming from ICMR. But for HSCT patient, it says that you can screen a patient for CP, carbapenemase, and for MRSA and also VAN-A, VAN-B, that is vancomycin resistance. So quickly, MRSA screening. So we know that most SSIs can be prevented through successful implementation of clinical guidelines. So Staph aureus colonized patients are up to 9 times more vulnerable to develop SSI. And we know these Staph aureus are mostly endogenous. So it actually affects the length of stay very badly. Cardiac surgery by 23 days, vascular procedures some 10 days, and hip replacement by 17 days. We have data, although Western data, but we have data to suggest that. So what's the solution? Yeah, we can actually go for screening. So preoperative screening and subsequent decolonization. Otherwise, if you go for empiric decolonization for each and every patient, there may be more mupirocin resistance, and which is perhaps not so supported. So time matters, and definitely you can, if you are able to screen and if you can decolonize, or if you do not have the time for decolonization, you can actually give some anti-MRSA drug for antimicrobial prophylaxis, and subsequently post-op you can isolate the patient. So these can be very innovative strategies for India. So we have this system where you can detect these genes, resistance genes, in a quick amount of time. Same goes for VRE, and for a select group of patients, these patients can also be screened, and again this is endorsed by ICMR, but for HSCT patients. So coming to the therapeutic strategy or precision medicine. So this is a new term, so where we can actually find out the best possible antibiotic, whether we should go for colistin or what's the best possible antibiotic to combine with colistin, or if in the best possible situation we can spare colistin. So this is feasible by this genotypic knowledge. So this is from the pure colonies, you can do this, and you can actually find out what kind of, okay, if you look into this slide, so this will give you a fair amount of impression why these newer antimicrobials need a knowledge of this genotypic classification. So ceftazidime avibactam, this is active against KPC and OXA48, and other antibiotics, although this is not yet available, but definitely need to have a clear knowledge of this genetic carbapenemase resistance genes. Otherwise, you are not going to utilize these antibiotics to the fullest potential. So this is enzyme-based therapy for XDR Klebsiella, pretty common condition for our country. So this slide, this publication is actually very good. It shows that if the Klebsiella pneumoniae is resistant to carbapenem, tigecycline, aminoglycosides, so how you should select your antibiotic. So based on the KPC, NDM, OXA48, and Porin loss or efflux pumps, it gives you a clear guidance what should be the right antibiotic to combine with colistin, or if in the best possible situation, if you can spare colistin. So all this knowledge is available when you have this therapeutic knowledge, when you have this genotypic informations available. Now this is a very recent guideline coming from ICMR, released just few days back. So this is on the guidance on diagnosis and management of carbapenem resistance gram-negative infections. So here you can see all these platforms. You can see this expert CARBA-R having this detection of carbapenemase genes feasibility and sensitivity of 100% and specificity 100%. So this is an approved test. The source is from isolate. Finally, the C. difficile testing is an excellent marker for your hospital infection prevention activities, your antimicrobial stewardship, housekeeping activities, and also your hand hygiene. So this can be actually integrated into your stewardship practices. So the present challenge is time, and also the toxigenic culture is not practical, and whatever serological tests you are having, these are having low sensitivity, and algorithmic testing can delay correct patient care. So definitely the molecular detection is much preferred, and actually this can help treating the patient and also curbing the infection being transmitted from one patient to another. So we have a lot of virulence factors associated, but this can be picked up by molecular methods. So we have this binary toxin and 027 strain, which may be important, and this can be picked up by molecular methods. So finally, how to implement a molecular rapid diagnostic test in your hospital? This provides baseline prevalence of MD or GNB stratified for different organisms, antimicrobial agents, and resistance determinants. It describes the availability of laboratory personnel during your study and consider reporting of time from identification or AST in the lab to actual therapy adjustments. So these are possible by this MRDT. It provides a clear definition of the study population and subgroups, and also correct comparison between rapid tests and combination of rapid tests. So moving quickly to the molecular test generally identify limited spectrum of microorganisms of resistance mechanism, and results of this AST are very useful proxy but not a definite proof of resistance. So you can have a very holistic idea what should be your right antibiotic to choose. Consider prioritization and consider feasibility of implementation of a 24/7 laboratory services. So to sum up, feasibility of a quicker screening in high-risk patients. So this is feasible with the help of molecular diagnostics, definitely rapid molecular diagnostics. And fast molecular methods offer the possibility of syndromic testing and enables early action for maximum impact, which is very important. And detection of resistance mechanism, which essentially brings to the concept of personalized medicine or personalized regimen or precision medicine to help identify the appropriate antibiotic regime. And the advantages of this molecular test is only possible when this is combined with systematic implementation into the workflow. So as a result, the MRDT should be implemented in an essential component of a well-functioning antimicrobial stewardship program. So thank you so much for your kind attention.